In the first part of a two-part series on dementia, we'll talk about the most common types of dementia and what it means to be diagnosed with these brain disorders. Next on Speak Your Mind. Welcome to Speak Your Mind. I'm Dr. Carolyn Phelps, licensed psychologist with the Human Development Center. While we most commonly think of Alzheimer's when we hear the word dementia, there are other types of these brain disorders. Tonight we'll talk about the differences between the normal aging brain and the most common types of dementia. Now, since this is a topic that people tend to have lots of questions about, start calling your questions in. Locally, dial 218-788-2844 or call toll-free at 1-877-307-8762. We'll be answering your questions throughout tonight's show. Joining me tonight is Dr. Michael Charland, a board-certified neuropsychologist in the Department of Neurology at Essentia Health. Thank you so much, Dr. Charland, for coming here. And I think a really great place for us to start would be on what the normal aging brain looks like and what we can expect, or what I can expect at least. I'm interested to know.
Sure, absolutely. So the sad truth is that memory, cognitive functionings usually peak around early 20s. And then they stay the same until we're in our early 30s, and then do start to slowly decline. So you and I are both on the wrong side of that slope.
Yes, we are.
Yeah. However, the changes that occur in a normal aging brain tend to be problems with memory retrieval. So if you think of memory as being like a filing cabinet, files are getting in, people have a little bit harder time pulling them back out. It's trying to remember the name of that actor in the movie that you like. But it doesn't really interfere with daily activities. So people are still managing their medications, paying their bills, food's on the table, those things are taken care of. So while there are some normal changes, it doesn't interfere, and that's where we go beyond the process of normal aging with cognitive functions.
I think a lot of people experience this word finding problem, and so it's not just even I can't remember the actor in that movie. It's that old tip of the tongue phenomenon, and I can't find that word. And where is that within normal aging versus not normal aging?
Word finding also is a common change as people get older. It's common to have some word finding problems. Word knowledge actually increases across the lifespan, so things like vocabulary increase, but being able to access that word when you need it in the middle of a conversation becomes a little bit more challenging as people get older.
And so part of this also is just kind of like there's sort of a slowing maybe of the connections, and it takes a little bit more time to access that information and not being as fluent as you used to be, or as we used to be maybe in our 20s and 30s then. Is that correct?
Yeah, that's correct.
And so that's what the normal aging brain looks like, and it's not a true statement that simply because we're aging that we're going to wind up at the point of dementia.
No, that's not true. Some people at times have thought that if you lived long enough you would develop dementia, but as we study successful aging, people that have aged into their 90s and 100s and still have good cognitive functions, what I like to say is there is no expiration date on the brain. So it's not after a certain point it's just no good. There are things that we can try to do to keep our brains working well even into older life.
Well, that's a great setup for the next question then, and what are those things that we can do to have a healthy aging brain?
Sure, that's a great question. One of the most important things, and where a lot of interesting research has been coming out in the last 4 to 5 years, is physical exercise. And so what the research is showing is that regular physical exercise, 30 minutes a day, 5 days a week, can really reduce the occurrence of dementia and actually improve cognitive functions. Originally, the thought was that it was increasing the amount of oxygen going to the brain, but they're finding things like brain-derived nerve growth factor is increased in the brain. It keeps the cells in the brain healthy.
And so that's one of the good proteins. that sort of gets into the brain, sort of the miracle grow for the brain, which we talked about on that first show in January. Remember when Dan Hurley was here and we talked about how good exercise was for us. And so now we have Dr. Charland telling us that, and it continues to be good no matter how old we are.
Absolutely, and no matter whether or not someone has normal changes with aging or has some neurological disorders like dementia or Alzheimer's disease, there still is benefit from physical exercise. Beyond exercise, the brain in certain respects is kind of like a muscle. So the more you use it, the better it works. So doing things that stimulate you mentally can improve general cognitive functions. Social supports are very important. People that are isolated tend to have more trouble with memory. Diet is important, and then managing other medical issues. So stroke risk factors like high blood pressure, high cholesterol, heart disease, diabetes, smoking, all those things are things that we can do to reduce our risk of developing cognitive impairment later in life.
Talk about how important sleep is to a healthy brain.
Well, sleep's very important. And it doesn't have to be insomnia. You can accrue a sleep deficit. So if you're just getting 1 hour less per night on a consistent basis, then your brain is kind of functioning like it's been up for 24 hours straight. And that's hard on the brain. The sleep is restorative. So it allows the brain to process things through the day and allows the brain to get the rest that it needs to keep those cells healthy.
And also that there's a lot of housekeeping that's going on while we're sleeping, a lot of taking out the trash, so to speak.
Yeah, there is, absolutely.
And apparently there's a lot of trash to be taken out, so that if you're not getting, if you're not getting that sleep, then where's that going? That's just kind of hanging out then in the brain.
Right. So the brain needs that sleep. It needs that restorative sleep. So it's not just the quantity, it's the quality of sleep that you're getting that really allows the brain to function to its best ability.
Now, if we go to the next step, and I'm going to bring up something that isn't even necessarily a dementia, but what I kind of think of is sort of a maybe milder, which is the mild cognitive impairment. Talk about how mild cognitive impairment is different from the normal aging brain and how it might be present in older adults.
Sure. So mild cognitive impairment refers to a stage or a syndrome where people are having objective problems on cognitive assessment. So on the memory tests and the tests of cognition that I do in my office, people are showing some deficits. And they're usually aware that their memory isn't as good as what it was. But it's not interfering with those daily activities. They're still managing their finances, they're still managing their medications. And it's the way you detect mild cognitive impairment is usually through a cognitive assessment, like the things that I do. The type of mild cognitive impairment, though, can be very important. So for example, one of the types of mild cognitive impairment is something called an amnestic mild cognitive impairment, where the primary difficulty is memory. And we know that folks that have amnestic mild cognitive impairment, a large proportion of those folks will progress to dementia within about 5 years. However, if someone has mild cognitive impairment that's not a primary memory issue, only about 15% of those folks progress. And so knowing the type of mild cognitive impairment can help your doctors understand the prognosis and how heavily they need to, or how strongly they may want to treat the problems before it becomes more of an issue.
And how are those people coming into your office then? And am I noticing changes in myself that I'm worried about, and then I'm talking to my doctor about them? Or is somebody else, is it severe enough where other people are noticing and bringing it to my attention?
Well, it can happen either way. So sometimes, especially in more milder cases, patients themselves are noticing problems and they're going and talking to their doctor. The most common referral that I get is someone who's in their 60s or 70s or even 80s, and they go to their doctor and they say, "Doc, I'm having trouble with my memory." And there's some basic screening tools that physicians can use, but it's hard to tell whether or not that's normal aging, dementia, or mild cognitive impairment. So they'll send them to someone like me, and we do a more comprehensive battery. Many times, though, it's the spouse or the children or the close friend that's noticing some changes, and the patient may actually be a little less aware of that.
And so it's important that people get in early, because we don't have a whole lot of interventions that we can do, but there are some that if you're talking about the amnestic mild cognitive impairment, there are some medications that can sort of slow the progression into dementia. And I'm just wondering, I know you're not a medical doctor, but in a mild cognitive impairment, with the people with the physicians that you work with, then are you seeing that there's an opportunity maybe to prescribe some medications where that can be helpful in slowing a progression?
Absolutely. So the medications we have, they're not perfect, but they are what we have, and they do show some efficacy. So the neurologists that I work with frequently prescribe, there's a couple of different medications. There's 2 classes that have been FDA approved. And if it looks like this really is the early stages of something that has a high risk to progress to dementia, then most of the neurologists I work with will prescribe medication to help with that. Then beyond that, that's when we talk about those behavioral and lifestyle changes that people can do to also, the way I phrase it with my patients is we want to stack the deck in their favor.
Absolutely. Always we want to stack the deck in our favor. Let's move on now to dementia. Alzheimer is I think first of all, a lot of people think of Alzheimer's and dementia as being synonymous and as if there's only one kind of dementia. We know that that's not true, but I believe it is the most common form of dementia. Is that true?
That's correct. It's the most common form of dementia in older populations. So all dementia is just a description of symptoms. All it means is that memory or other thinking abilities are interfering with someone's basic daily activities. And dementia doesn't talk about the cause. So lots of things cause dementia. Alzheimer's is the most common cause of dementia, but other things like Parkinson's disease, strokes, brain injuries, brain tumors, lots of things can cause dementia.
And so in Alzheimer's, what are sort of the hallmark symptoms, and how is an Alzheimer's dementia different from other kinds?
Sure. So early in the course of Alzheimer's dementia, typically what you'll see is memory loss and word finding difficulty. It's those 2 things. Now that happens normally as we get older, so sometimes it's hard to tell whether or not this is the normal aging process or something more so. But then it starts to interfere with those daily activities. Another thing that you'll see typically with Alzheimer's dementia is people don't remember that they forget. So I'll have folks that come into my office and they'll say, "Boy, Doc, I feel great. I can't remember the last time I forgot something." And their family member is saying, "No, something's not right here." So they truly don't remember that they're forgetting. And that's one of the hallmark symptoms that you can see with Alzheimer's disease.
I think that there is sort of an old wives' tale of if you forget where your keys are, that's normal. If you forget what you use a key for, that's dementia.
Yeah, I think that'd be more advanced dementia. By the time people don't know what a key is, we've gone down the road quite a bit. Early on, that's not something that you'd typically see. However, people repeating the same questions within the course of 10, 15, 20 minutes, asking the same question 4 or 5 times, that's not typical for aging. Forgetting to pay bills, forgetting to medication management, those types of things. Certainly when there's a change to medication can be more difficult, but those are things that we'd want to get checked out. We'd want to make sure that there's not something else going on.
And I know with Alzheimer's sort of later on in the progression that you have problems with, I think we refer to it as route finding, of losing your way, not knowing where you are in time and space. These are people who can walk out the door and then get lost. And that's later on in the progression?
That's typically later in the progression. The term that we use is wandering. And that is certainly a safety concern, especially here in the Northland. Things like winter here, when it's cold, people when they have a tendency to wander, they tend to be a little bit more confused, and so they may not take the correct clothing or the correct things with them, and they can get lost right outside their front door. And that's a big safety issue. So if someone is having some symptoms of wandering, if they're having some problems with that, we typically need to make sure that they're getting the amount of support they need in order to make sure that they're safe.
Let's talk about vascular dementia and how that's different.
Okay, so vascular dementia most basically is dementia caused from stroke. And it can either be from a single large stroke, or it can be from an accumulation of very small strokes that occur deep in the white matter of the brain.
And how would the symptoms be different then in vascular dementia from Alzheimer's?
So in vascular dementia, you can see some of it depends on the size and location. So if it's a large stroke, it really depends. It's all about real estate. It's the location in the brain.
Location,
Absolutely.
location.
That tells me what the symptoms are going to be. In what I see is more commonly an accumulation of small strokes deep in the brain. And what we'll see is more slowed processing speed. People just take longer to process information. We'll see troubles with executive functioning, which is this fancy term for all the things that the frontal part of the brain does, things like problem solving and judgment and decision making. Memory problems look a little bit different. If we go back to the filing cabinet analogy, what you see is that files get in, but they get stuck, and people have a hard time pulling them back out. One of the tests we give in my office is a list learning task. It's a memory test for a word list, and there's 12 words. And after 30 minutes, we see how many words a person can remember. Someone with Alzheimer's may get 0 on that. So would someone with vascular dementia. But then we ask them, well, was this word on the list, or was that word on the list? It's a recognition memory task. With Alzheimer's, the recognition cues don't tend to help that much because the files aren't in the filing cabinet. But someone with vascular dementia, they may get 10 or 11 or even 12 out of 12 words showing that they're in there, they're just getting stuck.
And are you also saying then with the vascular dementia that is caused by sort of more of the mini strokes, the ischemic attacks, that sometimes the way in which these people are coming to others' attention is because they're presenting then with these memory problems, and that otherwise they're not necessarily, because you're not having a big, huge event that lands you in the hospital necessarily? That's
correct. Many times with these small subcortical strokes, you'd never know you had one. It's not until people are reporting other symptoms, memory issues or whatnot, and they do some brain imaging, an MRI, will show this accumulation of small strokes in the brain, and that's when they find out that they've had some of those.
Here's a question from George in Knife River, he's 70 and George is a man, in good health and good memory of childhood, but forgets names occasionally, and he's asking, should I be concerned?
Well, remote memory, remembering childhood things, where you grew up, what your phone number was, those types of things, that doesn't change much as we get older. It's really hard to get rid of those old memories. It's the new learning. Occasionally forgetting a name isn't that big of a concern. What I would recommend is that if you're worried about it, you speak to your doctor, because there are brief cognitive screening tools that can be used in your primary care clinic that can see, should we be concerned? So sometimes trouble coming up with names is normal, sometimes it's not. It depends somewhat on the names you're having trouble coming up with. An actor or a distant relative, not too concerned about if you're having troubles recalling the names of your children or your grandchildren. It's a little bit more concerning. I'd certainly want to speak to your doctor about it.
And even if your doctor says you have an acute case of nothing at all, isn't that the best delivery of news?
Absolutely.
Because then you don't have to worry anymore.
I mean, my favorite case is when I get to tell someone that they look great, that their brain looks healthy and everything looks good. I've alleviated their concerns, and I get to give good news.
I know.
I don't get to do that often. So.
Here's a caller who wants to know if hearing loss is linked to dementia.
There's been some interesting research recently with hearing loss and dementia, and what they have found is there is a connection. Now, we don't really understand whether or not it's a neurological connection, that somehow hearing loss is causing dementia. I wouldn't go that far. But we do see a correlation. People that don't hear well do have a greater tendency to have a diagnosis of dementia. Haven't seen the flip side where if we treat hearing loss, it reduces the risk. But there is a connection there.
And let's go on and talk about another kind of dementia, Lewy body dementia, which I feel like I know more people who have a parent or another family member where I feel like I am hearing the phrase Lewy body dementia with much more frequency than I ever have before. And so my first question to you is that just me, or are we seeing an increase? Are we better at diagnosing that?
I think there's a greater awareness of Lewy body dementia. Lewy body dementia is arguably the second most common cause of dementia. Some people say it's a vascular or a mixed vascular Alzheimer's, but Lewy body is certainly one of the more common types of dementia. It wasn't studied a great deal until about 30 years ago. So as we've learned more, we see it more often. Typically folks will present with symptoms of Parkinson's, but then they also have these fluctuations where there's days or times of the day where they're sharp and alert and with it, and other times where they could fall asleep in the middle of breakfast or they're more confused. Visual hallucinations are one of the hallmarks of Lewy body dementia. So people start seeing, it's almost always people or animals. They'll start seeing, a kitty cat run through their house when they don't have a pet, or they wake up and they see someone standing over the bed who fades into the walls. So Parkinson's symptoms, visual hallucinations, fluctuations, acting out of dreams, those are some of the hallmarks of Lewy body dementia.
And when you say Parkinson's symptoms, you're talking about some of the movement problems.
Right, so it'd be stiffness or rigidity. Sometimes it can be a tremor. It can be changes to the way people walk or their balance, those types of symptoms.
And I think I read, in preparing for the show, I read something that if what has happened to you first is the movement problem, that's probably more likely to be Parkinson's. And if what you experienced first was symptoms related to memory, and the movement problems came second, that it's more likely to be Lewy body dementia. And what do you know about that? Because maybe
Sure.
I didn't read the right thing.
Well, certainly if the cognitive issues started, followed by the Parkinson symptoms, what we call Parkinsonism, that would be definitely more concerning for Lewy body dementia. However, what we want to see is we want to see a closeness in time. So if you start with Parkinson's symptoms, but then within 2 to 3 years are showing signs of dementia, that also would be considered Lewy body dementia. You can have some cognitive changes with Parkinson's disease, but you wouldn't expect it so early on in the course of the disease, which would certainly be more concerning for Lewy body.
And here is a caller called in and said, Sam, I don't know why I'm holding this one when I'm reading this one. Sam from Cloquet said, 80-year-old father is falling. Is that a sign of dementia?
Well, people can fall for lots of different reasons, but falling is a big concern. So if someone's falling, if your father's falling, you'd want to get in and find out why. Because things like neuropathy, if people can't feel their feet, they're off balance, they're more likely to fall. Sometimes syncope or heart issue can cause falling. And then there are certain types of dementia where falling is common. These are more along the lines of a Parkinson's or a Lewy body or what's called an atypical Parkinson's dementia.
We're getting short on time here. Here's Alicia from Duluth who calls and says, if you have a TBI, what is the best way to determine if dementia has begun? And then she starts naming things like, would you need an MRI or a CT scan?
So an MRI, CAT scan, and neuroimaging in general with dementia is usually used to rule out other causes. So it's great to take a picture of the brain. We want to look at all those structures, but a lot of times it's not telling you very much how the brain's working. So typically that's where I come in. And what I do is I look at brain functions. And so if someone had a traumatic brain injury and was concerned that they were developing dementia, you'd first want to talk to your doctor, but then see someone like me where we can look at your brain functions and see how they are performing and whether it fits with something that we'd see from perhaps traumatic brain injury versus something else going on like a dementia.
And so we have about 1.5 minutes left here. And what would you want to say for your parting words, Dr. Charland, for our viewing audience of what you think is important for them to know?
Sure. I think that's a great question. The thing I would say to folks the most is, one, if you are concerned, either yourself or a loved one, talk to your doctor and keep talking to your doctor. One of the things that happens is commonly get a pat on the head and say, oh, we're all getting older, it happens to the best of us. But if you're concerned about it enough to speak to your doctor, that means that something needs to be done, we need to work it up. So keep asking. And know that even if there is something going on, if it is dementia, if it is Alzheimer's disease, we can't fix it, but we can do something about it. This isn't something where we throw our hands up and say, well, it is what it is, there's nothing we can do. There's always something we can do, even if we can't fix it.
I think that's a wonderful message of hope, and you know how I am about the message of hope. I'm always, you know, that's what I'm all about here. And I think we just do kind of feel that way, don't we? That oh, dementia, there's nothing we can do. Dr. Charland just told us, au contraire, that's not true. The other thing that he made a big point is that we all can be doing things right this very minute to improve our brain health, no matter how old we are, so that we, as he said, stack the deck in our own favor. And why do we not want to do that? Y'all were great calling in questions tonight. Thanks so much for joining the discussion. And don't forget to visit us on the web at speakyourmindonline.org, where you can find a schedule of our topics and resource links. And join us next week when we'll be talking about the experiences, needs of families and caregivers on changing roles when someone you love has dementia. I'm Dr. Carolyn Phelps. Thanks for watching, and good night.